We'll be doing a short series on the gastroenterology topics from Harrison's point of view. It will be a sort of a recap of the things that we discussed, which was primarily based on Schlesinger. So I hope this will be useful. In my first session, I'll be talking about esophageal diseases and approach, followed by peptic ulcer disease and related syndromes. So coming to esophagus, what are the symptoms of esophageal disease? The most common symptoms are heartburn, regurgitation, chest pain, dysphagia or rhinophagia, and a globus sensation. So each of these things have a lot of aspects in common. So a patient with gastroesophageal reflux disease, for example, will present to you with symptoms of heartburn, but may also have symptoms of dysphagia. They might say something like, sir, I feel that whenever I swallow, there is a feeling of food stuck here and I might have to drink some water to pass it down. So even though technically we say that dysphagia is one of the alarming features of upper GI symptoms which would immediately require an endoscopic evaluation, what we need to also know to temper these facts is that most of patients, at least 30-40% of patients with severe GERD can have coexistent symptoms of dysphagia too. So when you know that these are the symptoms of esophageal disease, at the same time you should be aware of the fact that most of these things can be overlapping. So you have to take a combination of these factors to decide whether an endoscopy is required or not. So heartburn is very classically associated with GERD, but at the same time people can have a gastroparesis, features of bloating, which can be very commonly seen in functional dyspepsia. So they might come and say that it's a burning sensation. So automatically it does not necessarily mean that it is due to GERD. So there's very little, concordance between what the person says and what kind of pathology that is underlying. And for example, another very important thing to know is about dysphagia. So in dysphagia, patients will come and tell you that I have a specific foreign body stuck here. They might actually come and say that I know that this is where I have a feeling of obstruction. So you might automatically think that the pathology is in the cervical esophagus, but it's been actually documented based on studies that in around 30-40% of cases, a distal esophageal obstruction due to GERD or a malignant pathology, to the patient, it appears as if it is the level of obstruction is up here. So cervical esophageal foreign body sensation may not necessarily mean that the obstruction is at the level of the proximal esophagus. It could be at the level of the distal esophagus. This is because all these are visible sensations and the patient, despite their avowals, may not be able to localize it to a particular level. Now, chest pain is interesting because this is an area that has got commonalities with the heart, and a lot of these pathways do also overlap. So you might have patients who have underlying cardiac problem sitting in front of your OPD when you're a gastroenterologist, or the other way around. As far as a gastroenterologist is concerned, one of the very specific things when you think about chest pain is to rule out spastic disorders of the esophagus, very specifically distal esophageal spasm, or previously called diffuse esophageal spasm, where you have a corkscrew esophagus. So when patients have classical symptoms of severe chest pain that lasts for a very short period of time, but it's a very significant burst of pain, and an associated dysphagia during the period of chest pain, that is very specific for distal esophageal or diffuse esophageal spasm. Rhinophagia, on the other hand, is very classical for pill esophagitis, or a dysphagia that follows after a foreign body, like a chicken bone is stuck in your throat, or in very rare situations, severe infective esophagitis like CMV esophagitis or HSV esophagitis, you might have rhinophagia. But rhinophagia very classically goes in favor of a pill esophagitis. Globus sensation can accommodate any of all these symptoms. At the same time, you may not have any underlying pathology. Patients can have a subjective sensation of something stuck in their throat, in the lower part of their throat. But when you do an evaluation, you might not find anything. So it can be a symptom of a functional dyspepsia also. So a person with symptoms comes to you, you decide to do an evaluation based on the age of the patient, based on the alarm features, whether there is associated features like weight loss, family history, significant alcohol intake, smoking, or even a typical history of taking a pill that is known to cause pill esophagitis. What are the at this point of time, what are the different evaluations that are available to you? So the most common and the most routinely used is endoscopy. It is slightly even overused, that we all know that. But in India, because of the increasing availability of this is one of the most common investigations that we do. And endoscopy is important for ruling out structural pathologies and for grading the severity of GERD. Sometimes when we are very sure that it is due to a GERD, we do an endoscopy nevertheless, not to just make a diagnosis of GERD, but also to find out whether there is any Barrett's esophagus, and so that we can take biopsies. We do an endoscopy to rule out pill esophagitis, to rule out foreign bodies, and we also sometimes rule out malignancy with an endoscopy. Barium swallow, when it comes to radiological features, one of the last remnants of indications for barium swallow is in the situation of esophageal motility disorders, for which it is still routinely used and it is very, very useful. So what happens is when a person comes to you with dysphagia, very commonly it is known that when you do an endoscopy, you might miss the diagnosis of an underlying esophageal motility disorder because the mucosa is absolutely normal. So whenever somebody is complaining to you with dysphagia, you have to do an endoscopy, definitely, but you also have to suggest a barium swallow because that can pick up an underlying achalasia cardia even when your endoscopy misses it. Esophageal manometry is usually done after you do an endoscopy or a barium when you have a significant pretest probability that you're dealing with an esophageal motility disorder like achalasia cardia or esophageal spastic disorder like distal esophageal spasm. Whereas a functional luminal imaging probe gives you a correlation between the volume of the esophagus and the distensibility of the esophagus. Again, this can be useful in denoting the type of achalasia cardia, especially it is useful after you do an intervention for achalasia cardia to find out whether the intervention that you performed has actually brought about an improvement in the pathology of the individual. Finally, in patients who have gastroesophageal reflux disease, where you have performed an endoscopy, you have documented that there is GERD or you have documented that there is no GERD, if the patient has got persistent symptoms, doing a pH testing where a probe, either a capsule that is stuck to the lower part of the esophagus or a linear probe that is passed down your nose, is placed at the lower end of the GE junction for around 24 hours, and you have something called a 24-hour pH metry monitoring system, where the amount of time that the esophagus is exposed to a high pH, to a lower pH is recorded. For example, that is called the acid exposure time. So if the significant acid exposure time is more than a particular percentage, then you have a scoring system that tells you that this person usually suffers from underlying GERD. So this is basically done to find out a correlation between the GERD that is commonly seen in a lot of individuals and the symptoms that the patient is suffering from. If there is no correlation between the acid exposure time and the symptoms that the patient has, then there is no reason to perform a surgical procedure for these patients to reduce reflux. For instance, the acid exposure time more than 6% is significant for the amount of acidic exposure to the lower part of the esophagus.